Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We're at the Alan B. Levan Innovation Center, which is a combined effort between NSU and Broward County. And today we have a much requested program, Parkinson's Disease Update. And when we decided to seek out an individual, we found an excellent representative of knowledge in Dr. Henry Moore, who is the medical director of Miller School of Medicine, PD and Movement Disorder Center. Did I get that all in correct?
Well, I am the director for the APDA, so the American Parkinson Association connection with university.
Okay, well, I was going to get to that too, but you just said it, so I'll repeat it. It's the American Parkinson's Disease Association of South Florida Center. Okay. Chapter. Welcome, and talk to us about what your center or chapter is all about.
Well, thank you. Thank you for the kind words and the invitation. So I am Henry Moore. So I'm one of the, I work at the University of Miami. I'm an assistant professor of clinical neurology and part of the movement disorder division that is also have inside the Parkinson Disease and Movement Disorder Center at University of Miami. We also have a strong relationship with the American Parkinson Disease Association, and we have I am the director of the coordinator and referral sites for them here on South Florida. So I'm happy to be here and give you some information, updates on Parkinson disease, what is new and what is coming, what is on the pipeline.
Please, it's all yours.
So let's talk a little bit about Parkinson's disease for people that may not be familiar with this condition. So this is a neurological disease that affects mainly what we call central nervous system, which is the part of the brain, pretty much whatever is in our head, but also the peripheral nervous system, which are the nerves that come off the brain. And then a lot of these nerves end up, for example, on intestines, they end up on the skin, on the urine tract, they end up on the heart, etc., etc. So it's a disease of the brain, but also on nerves that come from the brain and they go to different parts of the body. The main problem on this condition, and this condition actually was described by James Parkinson's, which was a physician on 1817, so many years ago. And then the main problem of these patients is that they all get slowness of movements. So they will gradually get slow as time passes. The other feature is rigidity. The patient will complain that the joints are stiff, that the movement, that the arms or the legs became stiff. Sometimes they refer that as feeling heavy and difficult to move. And the third element is, so we have slowness, we have stiffness or rigidity, and the third element is what we call tremor at rest. And so some, not all of these patients develop some tremor, usually in the upper extremities on the hands, but could be also on the legs. And then usually happen when the arms or the legs are completely quiet. So and the fourth element that comes sometimes later on the disease is the postural instability. So these patients, as the disease progresses, may develop gait and balance problems. So the way we do the diagnosis is clinical. It's based on the symptoms, and the main symptom is the slowness of movements. We also need, in order to make the diagnosis, to make sure there are no other causes of this. So because there are other situations, other conditions that can produce a slowness of movements. So we have to order, as neurologists, we order an MRI of the brain to make sure you don't have strokes or you don't have tumors that may be causing these symptoms. So Once the diagnosis is clear, and sometimes it's not that clear, if it's not that clear, the expert on Parkinson's or movement disorders, but they may order this an additional test called DAT scan, D-A-T, DAT scan, which is a study that tries to see if there are, what is the status of dopamine in the brain. So let's talk about dopamine and movement a little bit just for you to understand. Human beings move due to thanks to multiple elements in the brain. And one of these elements is a chemical called dopamine. So what happens in patients with Parkinson's is that the cells of the brain that make dopamine, some of them, a group of them make this chemical dopamine. This, for some reason, these cells start dying. So when the patient has 50% or less of those cells remaining on the brain, is when the symptoms come. So that means that for many years, you may have Parkinson's and may not notice it. And only when this half of these dopamine cells die is when the symptoms start arising. So the main aspect of the disease is then, at least on the movement part, and that's what explains the slowness, is the lack of dopamine. So dopamine, we call it equal to movement. So if you have normal dopamine, your movement will be normal. If your dopamine starts declining, then your movement will be slow and rigid and you will shake. But the interesting part is that besides this dopamine aspect, which is the one that explains the slowness, there are also other symptoms that may appear even before the slowness becomes evident. And these other symptoms are interesting. That's because the disease also attacks other areas of the brain, not dopamine areas, other areas that may cause other symptoms. For example, poor sense of smell. So a lot of patients say, doctor, I don't smell things as I used to do before. And then that may happen sometimes 10, 20 years before the onset of movement problems. Other patients may say, doctor, for some reason, I have constipation. I'm not taking anything new, I'm getting constipation. So constipation is one of the earliest signs, sometimes 15, 20 years before the onset of motor symptoms. Other problems are urinary problems, urgency to go to the bathroom, that on the males can be confused with, for example, prostate problems, but may not be. They may go to the doctor for prostate and the urologist, and he may say, you know, your prostate is fantastic, it's no growth. So that may be Parkinson's disease. Other problems that attack usually early include depression and anxiety. So mood changes, depression, anxieties with no clear reasons. Other problems even include problems on the blood pressure. So some patients stand up and they get lightheaded or dizzy a little bit. And then the other group of problems that are very important come from the sleep territory. So sometimes patients, but more often the wives or the spouse, let's say if it's the wife, if the female is the patient, the husband, they may say, Dr. Moore, my spouse has a problem. When he's sleeping, he sometimes starts talking at night, but not just that, it starts moving and then at times fighting, like he's fighting with somebody. And this is called REM, R-E-M behavior disorder. REM is a phase of sleep. But don't go with technicism. So let's go, what it is that the patients start having these dream enacting behaviors. And if you wake up the patient, then they will tell you that they were dreaming that they were in a fight with somebody, or they were dreaming that they were being attacked. So usually like an action, kind of an action movie occurring at night. So these patients that have this situation with no reason, they have higher chances to develop Parkinson's disease later on life. I'm saying 10 or 15 years later on life. So again, not all of them will develop Parkinson. I don't want to scare anybody, but and then usually it has to be confirmed with the sleep doctor. But this is one of the first symptoms sometimes. So you may have somebody that says they start shaking today a little bit, and the doctor examines and they find Parkinson's symptoms, the slowness, the stiffness, the walking difficulties. But then when you ask the patients on retrospect, they will tell you, doctor, 10 years ago, I was having constipation, I had poor sense of smell, and then my wife was telling me that it was kicking her or like punching her, during the sleep. So this is how Parkinson evolved. It's very slowly progressive. So let's go a little bit about then what we do. So once it's diagnosed, number one, doctor, is does Parkinson's have a cure? So can you do something to stop it and cure it? No. Does it have treatment? The answer is yes. Can we improve the quality of life of the patients? The answer is yes. So sense GAD is a neurological disease that is treatable and in which you can improve quality of life. So the main treatment will be for patients to improve the movement. They became slow. So the treatment will be to replace dopamine. So there are a bunch of pills, multiple different medications that can replace dopamine. The main one is called carbidopa-levodopa, which is a medication that when you take, it becomes dopamine in your brain. So it's a medication that is like an ingredient that when it goes to your brain, your neurons will make dopamine with. And then, so it will replace your dopamine levels. See dopamine as a gas on a car, no? So you don't have gas, you don't move. So you don't have dopamine, you move slow. So what we do, we replace your dopamine with pills. So the main pill is called carbidopa-levodopa that becomes dopamine on the brain. That was invented in 1967. So long time ago. It's still the best medication for Parkinson, the most potent and the one that has less side effects. But around that, carbidopa-levodopa, which is our bread and butter, so we have a lot of medication that may help the carbidopa-levodopa to work better, to last longer, to be more efficient. And what I say that is because when the patients start taking the carbidopa-levodopa, initially they feel fantastic. They feel fantastic. They feel that with maybe 2 or 3 times a day pill, they feel good. The rigidity improves, tremor goes away, the slowness gets better. But as the disease progresses, the patient may start having issues with the carbidopa-levodopa. They may say, doctor, it still works, but it doesn't last 6 hours. It lasts now 4. And I was taking it every 6 hours. So I feel that after 4 hours, I start getting slow again and shaky and rigid. So we call that a motor fluctuation, and we call it off when the medication doesn't work. So the other problem that happens sometimes over the future is that the patient may say, doctor, the pill works fantastic, but I notice that when the pill is working, an hour after I take it, I start having involuntary movements, like contortions with the face, with the arms, the legs. And these are called dyskinesias. And these are complications of the disease on the future. There are pills to control that. There are pills to fix the fluctuations, to make your medication last longer again. And there are pills to try to reduce the involuntary movement dyskinesias when they arise. But unfortunately, when after 15, 20 years of disease, you may see other problems that may not have solutions with pills, which are called balance issues. Balance problems, the patient may fall and they may require physical therapy and a walker as a walking aid to prevent falling. And then sometimes they have what we call freezing of gait, on which it's a very interesting phenomenon, which patients feel that the feet are glued to the ground, especially when they start walking or just for a few seconds when they turn. Some patients may also feel it when they cross a doorway, as in that transition for a few seconds. So in terms of innovative therapies or developments, let's say, that happen on Parkinson's over the years, and we still consider carbidopa-levodopa our main treatment, but what happened in terms of development? One of the big developments was the deep brain stimulation. And what it is, perhaps you already heard about that, or maybe have a friend that has had this procedure. So deep brain stimulation is a very interesting procedure on which a physician introduces a wire into the patient's brain to help alleviate the symptoms. So it sounds like very drastic and extreme, but it's not. They do little holes here on the skull, with patient awake, believe it or not, and they introduce a wire into the brain, and they connect the wire under the skin with a little box, like a pacemaker, but the box is under the skin on your chest. What the box does is releases electrical impulses, travel to your brain, both sides, right and left, and then these electrical impulses, what they do is restore the electrical activity deficient on the brain. And then doing that, what they do is what? Improve your slowness, improve your rigidity, may improve your tremors, may extend the duration of your pills, may stop the involuntary movement that may happen down the road, and then may also reduce, may you able to reduce the number of pills that you take. So we use this technique when the situation, the disease becomes more advanced, of course, but it's something that you need to talk with your doctor. You have Parkinson's disease to see if you are a good candidate or not for this procedure called deep brain stimulation, or the wires on the brain for patients with Parkinson's.
The show is driven by questions from our viewers for many, many years. And it seems that maybe it's because of the presentation of information that comes to them through multiple sources now, whether it be computers or cell phones or television or whatever it is, as to the number of people that are well known to the general public who end up with, in quotes, Parkinson's disease. One of the main, we've had multiple questions from individuals that want to know, since the state of Florida really has the greatest percentage of people over the age of 70 of any state in the union, is it particular to age, or is it something which is also a element of harm to the body, or whatever you want to call it, the action of the body at younger ages?
Yeah, very good question. So definitely, yes. The prevalence of Parkinson's on United States is less, is when you just get the people, for example, from age 45 to 55, it's less than 1%. So less than 1 out of 100 have Parkinson's when there is the ages 45 to 55. But you get people on the other extreme, more than 85-year-old, then you see Parkinson's between 2 to 4%. So definitely Parkinson's disease increases with age. And again, doesn't mean that everybody's going to develop it. I'm just saying 4%, for example, will be the most over the age of 85, but definitely increase with age. The second statistic of importance is that it's more common in men than women. So, which is an interesting factor. I'm not going to go into details what are the supposed theories for this, but this is another interesting fact. And the other fact is that there are some external factors, extrinsic factors that may trigger Parkinson's. For example, it has been associated with pesticides use. So patients that are exposed, or they were exposed through their lives to pesticides on a significant amount, may end up having a higher risk for Parkinson's. Finally, the other factor will be the genetics. So look like, and the more we study, the more we realize that we know that from all the patients with Parkinson's, maybe 5 to 10% have an abnormal gene that is triggering the Parkinson's. So that is the main causative agent or the main cause of the Parkinson's. And then on the rest, let's say the 90%, there is no clear cause. So genes present on 5, 10%, 90% of the cases, you don't find any abnormal gene, nothing. And then these genes became important because nowadays we are developing some therapies that may slow down Parkinson in specific patients with specific genetic varieties of Parkinson's. Again, you don't know that just unless you do a genetic test on the patient. And there are some ways to do it and try to identify, especially if you have family members with Parkinson. That will be interesting.
Let me ask you this question. With reference to that, there are, again, the elements of noticing that you have something occurring which brings you to the physician, and you know, whether it's be shaking the hands or everything that you discussed, you know. But the people out here that have asked these questions have found that there's very little, I shouldn't say, less than adequate, perhaps, knowledge of the areas of Parkinson's that you have just discussed rather completely to the point where we're at now. And yet there are very few venues available for people to seek out Parkinson's care other than prescribing what's in handbooks or other pieces of information that come through journals. Do you find that to be true?
Completely true. And I'm going to give you some additional input there. So Parkinson's disease is not that simple. Now that I kind of gave you a little bit of the background of Parkinson's, and then it involves multiple areas of the brain, not just the dopamine. Dopamine explains the slowness, but there are other areas of the brain, including cognitive areas of the brain, so areas centered that normally give you memory, attention, concentration, etc. So, and then patient with Parkinson may also develop some form of dementia associated with Parkinson. So multiple areas of the brain that requires at some point a specialist, somebody that kind of is aware of all of the potential symptoms, motor and non-motor symptoms of Parkinson's, and may give solution or may give you the best treatment for each of them, knowing that these treatments may interfere one with each other. So it's always good to have an evaluation with a Parkinson expert. We call it movement disorder specialist, at least at some point during your disease. Of course, if there is doubt on the diagnosis, definitely you should be seen by a movement disorder specialist. Sometimes a neurologist, the general neurologist may have doubts, and in that case, the patient should be referred. And of course, if the treatment is not working well, and then it's always you should go to a movement disorder specialist to kind of refine, to tune the treatment, and also to explain to you the available options that exist, including this surgical. No?
How does one get to you, and not necessarily you, but your team at the center? Tell me how that happens.
Very good. So I am part of the University of Miami, and we have a Parkinson's disease and movement disorder center, which is comprised of 6 movement disorder experts. Some of them working on Miami, Broward, and also Palm Beach. I'm working primarily at the Boca Raton office, which is on Palm Beach. So if you want to reach our offices, you can just call to this number. Is 305-243-6732. So we're going to repeat it, 305-243-6732. This is our neurology office at the University of Miami. So you just, when you just get there, you just ask to be transferred to the Parkinson's disease area, and then they will do it.
Do they need a reference from the family physician or special?
Yes, if you have a referral, it will be fantastic. But when you call that number, they will tell you all the steps, the administrative steps, in order to get to the doctor, including the insurance verification, etc. Yeah, but we have all we have a significant group of not just movement disorder experts. We have a neurosurgeon that does the deep brain stimulation. We have nurse practitioners that can work with you. And we have an incredible team of therapists, physical, occupational, speech therapists, nutritionists. We have an interdisciplinary clinic for Parkinson's disease, also for special cases in which patients need more assessment from different specialties the same day. So we have significant capability and significant research. We're doing significant research on multiple medications on which some patients may participate, of course, if they are willing to.
Well, I'm glad to hear that because one of the mantras of our founder here at Nova Southeastern University Health Professions Division absolutely insisted upon collaborative health care. I want to thank you, firstly, for your knowledge, obviously, but also I could see you're a person that believes in caring for others, which is very important. I mean, the most important feature, like I said, our founder has always said, if you don't care for your patient, all your knowledge is going to go someplace else. It doesn't mean anything. So I want to say one more time, Dr. Henry Moore, the medical director of UM School of Medicine, PD and Movement Disorder Center, thank you for your time today. I know there'll be a lot of people that will ask questions, and we'll send them your way. And hopefully that you could bring some peace and health to the rest of their lives, which is most important to all of us.
No, thank you for the opportunity to be here. And again, we are all here. We are 6 movement disorder specialists ready to take care of you for any consultation or any help that we can provide in order for to help you battle with Parkinson's disease with the best quality of life. Thank you for the invitation.
Once again, I want to thank Dr. Henry Moore, as I said, the medical director of UM School of Medicine, PD, and Movement Disorder Center. Folks, if you have any questions, there's a telephone number and an address right here. And if you will send them on to Dr. Moore, and I'm sure that he'll do the best he can to help you. Remember, I always say to you, if something is bothering you, you've got to see your physician. Don't just sit back. You know, present yourself. Don't buy something in a supermarket or a pharmacy and think that you're going to help yourself. Talk to your physicians. Remember, this show is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.